Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from OTSCA.
This program is presented by Medscape Education Global.
Hello everyone, my name is Hiddo Lambers-Heerspink. I'm Professor of Clinical Pharmacology and Clinical Trials, and I have been involved in clinical trials in patients with IgA nephropathy. It's my great pleasure to discuss today developments in the treatment for IgA nephropathy. And I would like to welcome you to this program entitled Why Target APRIL in IgA nephropathy Management? Get up to speed with the mechanism of action and key data. And I have the great privilege of being joined today by Chike Chung. Chike, could you please introduce yourself?
Hello, I'm Chike Chung. I'm a consultant nephrologist and honorary associate professor based in the University of Leicester, UK.
Welcome, Chike. And a great pleasure to have you next to me today and discuss the role of APRIL and BAFF inhibition. In today's program, we'll discuss the role of B cells in the immunopathogenesis of IgA nephropathy and the rationale for emerging therapies. But before doing so, how common is IgA nephropathy? IgA nephropathy is most common in East Asia patients. It's common in white and relatively rare in black patients. In North America and Western Europe, the ratio of male to female diagnosed with the disease is 2:1. But in East Asia, both sexes are equally affected among the population. And we know that IgA nephropathy is associated with a high risk of kidney failure. About 50% of patients develop kidney failure 10 to 20 years after their diagnosis. Studies from the UK have demonstrated that in particular patients with elevated proteinuria are at high risk of kidney failure. And traditionally, we have always focused on patients with proteinuria levels of more than 1 gram per day because we saw that these patients were at highest risk of kidney failure. And that's true. But more recent data also demonstrate that patients with a proteinuria level of 0.5 to 1 gram per day also develop and are likely to develop kidney failure. Actually, 30% of patients with proteinuria levels between 0.5 and 1 gram per day will develop kidney failure within 10 years after their diagnosis. Data from the RADAR study show that 10 to 20 years after diagnosis, 50% of children will reach kidney failure, and about 75% of adults will also reach kidney failure. And in particular, people with higher proteinuria levels are at high risk of kidney failure. Traditionally, a threshold of 1 gram per day was considered to be at high risk of kidney failure, but more recent studies, including those from the UK from the RADAR study, show that even patients with a proteinuria level between 0.5 gram and 1 gram per day are at risk of kidney failure, with about 30% of patients reaching this dialysis or kidney transplantation within 10 years. And thus the KDIGO guideline now recommends to target proteinuria levels to less than 0.5 gram per day and has an ambitious target to stabilize GFR decline to levels less than 1 ml per minute per year decline. So it's important to early identify patients with IgA nephropathy because we now have new therapies that can reduce proteinuria and can slow the progression of kidney disease. And with these new therapies, we also have to identify early IgA nephropathy because earlier intervention will delay the progression of the disease and thus will also delay the onset of dialysis. We have new therapies. Traditionally, we use RAS inhibition. Nowadays, we have SGLT2 inhibitors, endothelin receptor antagonists that target the common pathways of disease progression. But today, we also talk about disease-specific immune-mediated drugs that target these specific immune-mediated pathways of disease progression. And that will then also lead, most likely, to a further delay in dialysis if we use these drugs at the right point in time. So let's now dive deeper into the pathogenesis of IgA nephropathy. And Chike, can I ask you, what can you tell us about the role of B cells in the pathophysiology of IgA nephropathy?
Thank you, Edo. So we now know much more about the pathogenesis of IgA nephropathy, and it's widely accepted that there's a multi-hit hypothesis. It starts off with the mucosal immune system and production of B cells that are more prone to releasing a form of IgA that lacks galactose residues from within its hinge region, and this is so-called galactose deficient IgA1. So we could see that B cells are really central to the pathogenesis because they're producing this pathogenic form of IgA. This Gd-IgA1 or galactose deficient IgA1 enters to the circulation at higher concentrations where it's recognized by other antibodies. And then these bind together to form immune complexes that could trap other proteins, for example, complement proteins, that then traffic towards the kidney and then get trapped within the glomeruli and then trigger an inflammatory and pro-fibrotic reaction that ultimately leads to kidney damage. So we can see that B cells are really at the heart of the pathogenesis, both by producing the pathogenic forms of IgA, but also the antibodies that are formed towards this that then drive immune complex formation that then trigger the kidney damage.
Chike, and then why is it so important to target the B cell pathway in IgA nephropathy? You just explained that B cells are actually at the core of the pathophysiology of IgA nephropathy. So how can we target then these B cells and what therapies do we have?
So I think targeting B cells is exciting in IgA nephropathy because they really are upstream of the pathogenesis. And if we can target that B cell production of pathogenic IgA, then hopefully we'll be able to impact on downstream processes that happen after the IgA is produced. So to take a step back and to think about the normal production of IgA, so the mucosal immune system produces IgA in response to different triggers, antigens, bacteria, and this can happen via T cell dependent or independent manners. And we know that the cytokines BAFF and APRIL play a key role in driving naive B cells to produce IgA plus switch to IgA producing cells. For some reason in IgA nephropathy, there's this tendency to produce this pathogenic form of IgA, the galactose deficient IgA or Gd-IgA1 for short. And we think this is because there may be a hyper-responsive mucosal immune system triggered by the cytokines APRIL and BAFF in particular to drive B cells to producing those forms of IgA. So you can see that this is the reason why BAFF and APRIL is a very attractive target in IgA nephropathy. The other aspect is that APRIL also promotes plasma cell survival, especially IgA plasma cells as well.
So thank you, Chike. That was a fantastic overview of targeting the B cell pathway in IgA nephropathy. Now, with multiple classes of B cell targeted therapies becoming available, how do you differentiate them by their mode of action?
So there are two main classes of B cell modulators that target the cytokines APRIL or BAFF and APRIL. So we have monoclonal antibodies that target APRIL alone, and these are sibeprenlimab or zigakibart. And then we have fusion proteins that use the TACI receptor bound to the Fc portion of IgG. And these are called atacicept, povetacicept, or telitacicept. So we can see there are two different classes of drugs there.
So we have 5 new drugs in total that are currently in development. Some of them are already registered and are clinically available. And we expect that more of these drugs will become available in the near future.
Yes, absolutely. So not only do we have these B cell modulators that target APRIL or BAFF and APRIL, but there are other classes of drugs that are being developed in late stages of clinical trials or are already approved. One class of drugs are the drugs that target plasma cells by binding to CD38. So these are anti-CD38 monoclonal antibodies. The binding to CD38 depletes plasma cells and therefore reduces IgA and Gd-IgA1 production. So there are two drugs in this class, felzartamab and mezagitamab, which are currently in phase 3 clinical trials after promising earlier phase trial data. Then, of course, we have complement inhibitors, and there are several inhibitors of different parts of the complement pathway. The ones that are most advanced is a small molecule inhibitor that targets factor B, so that's iptacopan, that blocks the alternative pathway because factor B is very important in that alternative pathway amplification loop. And this drug is already approved for treatment of IgA nephropathy within the US and is improved in other countries as well. Then we have a drug that blocks liver production of factor B, an antisense oligonucleotide called cephasexin, which is in a phase 3 clinical trial. And then we have ravulizumab, which is a monoclonal antibody directed against C5 and blocks its downstream breakdown and activity. And with ravulizumab, that is in the phase 3 clinical trial called ICAN, and results will be announced at the ERA Congress.
Okay, so we have many new drugs beyond BAFF and APRIL inhibition, and I believe we also have endothelin receptor antagonists. Can you tell us a little bit more about that?
Yes. So once IgA is deposited within the kidneys, we know that several pathways are activated. And important pathways are the angiotensin 2 pathway, but also the endothelin pathway. We now know through your work that it plays a very important role in IgA nephropathy. So there are new ways to block that. We have a dual angiotensin and endothelin A receptor antagonist called sparsentan, which showed efficacy in a phase 3 clinical trial called PROTECT, and that is approved for use in many parts of the world. And also we have atrasentan, which is a selective endothelin A receptor antagonist, which your work has shown has a significant effect in reducing proteinuria and reducing kidney function decline in patients with IgA nephropathy.
So our understanding of the pathophysiology has improved a lot, and by increasing our understanding, we now have specific drugs that target different pathophysiological drivers of IgA nephropathy disease progression. And maybe for the future, we can even think about combining these different interventions, don't you think?
I think that's a very exciting thought, and clearly we'll wait more data from these combination
Yeah,
studies.
but first we have to test and assess the long-term safety and efficacy of the individual interventions. Yes. It was a fantastic synthesis of the importance of targeting the pathogenesis of more specific treatment of IgA nephropathy, GK. So coming back to today's topic, the B-cell targeted therapies, what would you say is the rationale for targeting APRIL compared with BAFF-APRIL in IgA nephropathy?
So thank you, Hido. I think that's a really interesting question and a hot topic at the moment. We know that both cytokines play important roles in modulating B cells in their differentiation, maturation, and the class switching of B cells to IgA producing cells. I would say out of the two cytokines, APRIL plays a really key role in IgA nephropathy in promoting that class switching and also the survival of plasma cells that produce the pathogenic IgA. So the rationale for targeting APRIL, we know it's effective through the phase 3 clinical trials, and also it provides that kind of selective approach to the treatment of IgA nephropathy. And the clinical data and the safety data looks very good so far. The rationale for targeting BAFF is important for earlier stages of B cells and their maturation. And we know that BAFF and APRIL have some overlapping and complementary roles, especially in that IgA class switching. So the rationale is that maybe by targeting a broader group of B cells, there may be higher efficacy or durability of response. We need to see that from the clinical trials and see whether by targeting broader populations of B cells, there may be effects on safety and tolerability as well. So I think the question is still out there, and we need to see the trial data to make some more conclusions from that.
Thank you very much, GK. So we talked a lot about clinical trial data. Maybe it's now time to really look at these clinical trials and review the trial data and what we have learned so far. So as already mentioned, we have APRIL inhibitors, sibeprenlimab, zigakibart, and on the other hand, we have APRIL and BEV inhibitors, atacicept, povetacicept, and telitacicept. Then we also have the anti-CD38 agents, mezagitamab, valsartamab, and let's look at the trial data from these different clinical trials. So let's first take a look at the clinical trial data with sibeprenlimab. This is the visionary phase 3 clinical trial where patients with IgA nephropathy were randomized to 400 mg sibeprenlimab or placebo and are followed for 2 years. The patient population shows that the average participant was around 42 years of age. The UPCR, so the proteinuria value, was around 1.2 gram per gram creatinine, and the mean GFR was around 60 mL per minute. The interim analysis was performed after 36 weeks of treatment showed that sibeprenlimab significantly reduced proteinuria by about 50% compared to placebo. And we know that such large reductions in proteinuria levels will ultimately translate into a long-term kidney protective effect, but that has to be shown by the trial data. The drug was well tolerated in these patients. Adverse events were similar between the sibeprenlimab and placebo group. Similarly, serious adverse events were not different between the sibeprenlimab or placebo group, and there were no deaths. The effect of sibeprenlimab on eGFR in adults with IgA nephropathy is currently still ongoing, and the data and the patients are still being followed. However, the first 48-week data just became available, and that data showed indeed a stabilization of eGFR decline with sibeprenlimab compared to placebo. This is the first 48 week of data. We still follow these patients for 1 additional year to assess the longer-term effects of sibeprenlimab on eGFR. So what about the other APRIL inhibitor, zigakibart? This studied in a phase 2 open-label study. That study showed that zigakibart reduces proteinuria by 60%. The long-term data also showed that zigakibart stabilized GFR. But this was an open-label study, a relatively small study, and we would like to have definitive evidence comparing zigakibart versus placebo on the effects and then assess proteinuria effects and eGFR decline. So a phase 3 trial is currently ongoing, and that trial will assess zigakibart at a dose of 600 milligram subcutaneous injected versus placebo. Similar to the other IgA trials, this trial will have an assessment of proteinuria and eGFR after 9 months, and the study will follow these patients for 104 weeks, so 2 years. We have not seen data from the phase 3 trial yet, and we are awaiting these data. Now, what about the dual BEV-APRIL inhibitors? The ORIGIN phase 3 trial is a clinical trial, a phase 3 trial of atacicept versus placebo. Atacicept is given at a dose of 150 milligram, and patients are followed again for 2 years with an interim analysis after 9 months to assess the effects of atacicept on proteinuria. Pre-specified interim analysis at week 36, 9 months, included 203 participants, of whom 106 were randomized to atacicept and 97 to placebo. Nearly all these patients were receiving a stable dose of the current standard of care, renin-angiotensin system inhibitors, and 53% of patients in the atacicept group, 55.5% in the patient on placebo, were already on a stable dose of an SGLT2 inhibitor. So these patients were treated according to the current guideline, with a lot of patients using already SGLT2 inhibitors. The 36 months interim efficacy analysis demonstrated that atacicept reduces the proteinuria level compared to placebo by 41%. Atacicept also reduced the galactose-deficient IgA levels by about 67%. So it is really targeting this root cause of the pathogenesis in IgA nephropathy. Then a third clinical trial There's also interim analysis data that has been published, and this is the BAFF/APRIL inhibitor telitacicept. Telitacicept was studied in a phase 3 multicenter double-blind randomized trial in China specifically, and the efficacy and safety data of telitacicept are now available. The study enrolled adults with a biopsy-proven IgA nephropathy and included patients with persistent UPCR greater than 0.8 gram per 24-hour. Patients were required to have a stable dose of a RAS inhibitor, an ACE inhibitor, or angiotensin receptor blocker for at least 12 weeks, and were also allowed to use SGLT2 inhibitors. In contrast to the other studies, this study, as I mentioned, was done in China, and if you look at the baseline characteristics, we see that the GFR is a little bit higher than the other studies. In this study, the mean GFR was 72 mL per minute, compared to the other studies where the mean GFR was often around 60. But all these patients had significant proteinuria, indicating that they were at high risk of kidney failure. Telitacicept, just like the other BAFF/APRIL and APRIL inhibitors, significantly reduced proteinuria by about 40%. This study, in contrast to the other studies, also reported at the interim analysis the effects on GFR. In the placebo group, 27% of patients during the first 39 weeks of follow-up experienced a more than 30% decline in estimated GFR. In the telitacicept group, this was only 6.3%, so a significant difference already after 39 weeks of treatment in this endpoint of 30% decline in eGFR. Just like the other BAFF/APRIL inhibitors, telitacicept was well tolerated. There were no differences in adverse events and no differences in serious adverse events. Then there's a fifth APRIL or APRIL-BAFF inhibitor, povetacicept. Povetacicept has been studied in phase 1 and 2 studies. A phase 3 trial is currently ongoing. We haven't seen the interim analysis on proteinuria of this phase 3 trial yet, and we'll see this data in the near future. GK, could you tell us a little bit about the CD38 inhibitors and that clinical trial data?
Yes, so thank you for that overview, very comprehensive overview. And with the anti-CD38 therapies, these are a different way of targeting the B cells. And these treatments, felzartamab and mezagitamab, are slightly earlier in their development. So they are in phase 3 clinical trials currently. So these monoclonal antibodies, by binding to CD38, causes lysis of the cells, and CD38 is highly expressed on plasma cells and also on plasma cell blasts as well. These cells are responsible for antibody production and specifically for IgA. So dartamab has been studied in a phase 2 clinical trial where they studied 3 different doses compared to placebo. And what they saw was that by giving 9 infusions over a period of around 5 months, they could see reductions in proteinuria that were sustained out to 2 years compared to no change in the placebo arm. So anti-CD38 therapy offers the opportunity to give fixed dosing over a shorter period of time and potentially more sustained effects. And we saw similar data when looking at mezagitamab as well. I think the question is that CD38 is also expressed on other cells, such as natural killer cells. So it'd be very important in the phase 3 trials to also look at the safety and infection rates of the treated populations.
Important to know that this is a different approach. You treat for five months, and then you don't have to treat anymore, and you follow the patients. And the important question is also, when do you have to restart medication? Can you follow these patients for years without treatment? And do the proteinuria levels, is this reduction sustained, or do we have to restart at some point?
Yes, excellent question. And I think that is a key question to be studied at the moment. And probably different patients will have different duration of response as well.
Yeah, indeed. So we have reviewed the pathophysiology of IgA nephropathy. We've focused on the B cells. We have seen new therapies. What is most exciting to you, GK?
Yes, I think all the data that you've presented so far with the APRIL inhibitors, the BAFF-APRIL inhibitors, looks very promising in terms of not only reducing proteinuria, but that translating into protection against kidney function decline. And we are seeing early data that suggests a stabilization of kidney function, at least in the short term. But the other exciting aspect is that they are well tolerated and with no concerns, no significant concerns regarding adverse effects and infection rates at the moment, which I think is truly a very exciting development.
So in the clinical trials, we see that APRIL and BAFF-APRIL inhibitors are tested on top of RAS inhibition and SGLT2 inhibition in the most recent clinical trials. But if you think about where these drugs target the disease, just the underlying core part of the pathophysiology, should we rethink our approach, GK, and should we think about when do we start these therapies, and could we perhaps even start treatment with APRIL and BAFF-APRIL inhibitors in the future?
I think that's an excellent point, and that is also reflected in the recent KDIGO guidelines that we should address the two drivers of nephron loss, the immune-mediated drivers, and also those responses to nephron loss, the more CKD elements to the disease as well. So I do believe that we should be trying to start these therapies much earlier in the disease course. Of course, we need to recognize and diagnose our patients at a much earlier stage as well. But I think that our patients are likely to need the supportive care therapy with those treatments, as you mentioned as well, in combination in order to aim for the targets that you mentioned in the opening part of this session, the GFR loss of less than 1 ml per minute per year for the rest of the patient's life.
That's indeed probably the way to go forward, but we still need clinical trials to demonstrate that that approach would work. And thus, we're still not there, and we've made great progress, but there's still a long way to go to optimize the treatment. So we have seen that there is a progress in our understanding of the pathophysiology of IgA nephropathy has led to new therapies that can target immune-specific pathways of disease progression. We've reviewed APRIL and BAFF-APRIL inhibitors, and we've shown that these drugs reduce proteinuria, and small studies suggest that they even stabilize GFR. As we have discussed, the long-term effects and the safety from dedicated phase 3 trials are awaited and will become available in the near future. And of course, we look forward to seeing these data. I would like to thank you very much, GK, for joining us, and I would like to thank the listeners for listening to us, and we hope that these new data will help you in your clinical practice.
This program was presented by Medscape Education Global.